Imagine stepping into a time machine. You're back in 2004, right? And you are a surgeon operating at the absolute peak of your game.
Oh, the glory days.
Right, exactly. So you step into this time machine and you step out into an operating room next Tuesday.
Okay, I like where this is going.
Yeah, so you walk in, you scrub up, and you grab the drill. And for a moment, honestly, everything feels perfectly fine.
Sure, because the anatomy hasn't changed.
Exactly. The bone looks exactly the same. The implants are, remarkably familiar. The screws still go exactly where the screws go.
Right, it's muscle memory.
But, and here is the kicker, the moment you take off those gloves, drop them in the bin and step out of the sterile field, you realize your entire profession has been quietly hijacked.
Oh, man. Hijacked is a strong word, but it's accurate.
I mean, the procedure is identical, but the job is completely unrecognizable.
It's what we call the ultimate illusion of continuity.
The illusion of continuity. I like that.
Yeah, because we trick ourselves, right? We think that just because the physical mechanics of repairing a human body haven't radically mutated, the ecosystem around that repair is also stable.
Which is completely false.
Totally false. That time-traveling surgeon wouldn't just be confused by the new technology. I mean, they would be fundamentally disoriented by how their own value is calculated now.
Absolutely. And that is exactly what we are getting into today. Welcome to the deep dive. In this deep dive, we sift through the newest evidence and buzz around the evolving role of the modern orthopedic surgeon, cutting through the noise to bring you the insights, controversies, and must-know clinical takeaways. Tune in to get the context behind the headlines. Welcome to the #TheArmDoc, #DeepDiveOrtho.
I am so ready for this one.
Same here. And hey, we are looking directly at you, our listener, whether you're prepping for your first case of the day or maybe managing a regional clinic's operations or just trying to understand where the future of specialized medicine is actually heading. This is for you.
It really impacts everyone in the ecosystem.
It does. We are tearing into a source document today that's simply titled The Evolving Role of the Modern Orthopedic Surgeon. And the core thesis, it hits so hard because it strips away all those standard industry platitudes.
Oh, it completely ignores the fluff.
Right. Okay, let's unpack this. The author claims that the actual surgery is no longer the center of the surgeon's universe.
That is the paradigm shift right there, hiding in plain sight.
Right in front of us.
Exactly.
Yeah.
I mean, we are avoiding the standard debates today. We're not going to sit here and argue about the optimal angle for a femoral cut or the wear rates of highly cross-linked polyethylene.
Oh, thank goodness.
Right, because those are just technical arguments. The source material is demanding that we look at a profound identity crisis.
Identity crisis, that's heavy.
It is heavy. The scope of what it means to be a musculoskeletal care provider is being aggressively rewritten. And it's being rewritten by payers, by technology, and quite frankly, by patients themselves, all at the exact same time.
Wow. Okay, let's go back to our time-traveling surgeon from 2004 because the source uses this thought experiment to brilliant effect.
It's a great setup.
It really is. I keep picturing an executive chef from a Michelin star restaurant 20 years ago.
Okay, I see where you're going.
Right. You drop them in a modern kitchen. They still know how to perfectly sear a scallop. The Maillard reaction hasn't changed.
Sear is a sear.
Exactly. But suddenly, the sous chef hands them a tablet with real-time Yelp reviews.
Oh, boy.
Right. And the maitre d' is demanding they personally negotiate the supply chain cost of the butter.
Which is terrifying for a chef.
And it gets worse. The diners are literally in the kitchen asking if the scallops were ethically harvested, according to some TikTok video they just watched.
That is a perfect analogy.
The cooking is intact, but the environment is absolute chaos. So what specifically hits our 2004 surgeon when they walk out of that OR?
Well, the very first wall they hit is the sheer compression of time and space regarding patient recovery.
Compression of time. Explain that.
Okay, so 2 decades ago, a total joint replacement was a major multi-day inpatient event, right?
Oh, yeah, you were in the hospital for days.
Exactly. It was this institutionalized, slow-moving recovery process. The hospital basically absorbed the patient.
Right. They were in a bed on the orthopedics floor.
But today, that surgeon walks out of the OR and is casually told the patient they just gave a brand new knee to is going home in 4 hours.
4 hours. That would blow a 2004 surgeon's mind.
It would short-circuit them. The shock isn't the surgical technique. It is the massive, highly optimized operational machinery required behind the scenes to make a same-day discharge actually safe and effective.
Right, because that machinery isn't just, nurses and physical therapists checking on anymore. It's a wall of metrics.
Literal wall.
The text highlights this incredibly stressful concept, the administrator's dashboard.
Oh, the dreaded dashboard.
Seriously. In 2004, a surgeon's value was their reputation in the doctor's lounge, maybe their overall case volume.
Yeah, if you were busy, you were good.
But now, the moment their name is mentioned in an operational meeting, a dashboard just pops up on a screen.
It's the quantification of the physician, and it is absolute.
What are they tracking exactly?
Everything, every minute of turnover time in the OR, the specific cost of the disposable supplies they prefer, their 30-day readmission rates, their patient satisfaction scores.
Wow.
Yeah, all of it is tracked, risk-adjusted, color-coded, and projected onto a giant screen.
That is so intense. So the time traveler expects to be judged by the elegance of their closure, right?
Exactly.
And instead, they're being judged by their variance from the mean supply cost per case.
Which has nothing to do with their hands. And then it gets crazier. They walk into the clinic.
Oh, right. Let's talk about the clinic.
This might be the biggest culture shock of all.
Why is that?
Well, in the old days, the surgeon was essentially the oracle.
The oracle. I love that.
Right. They held all the sacred knowledge. The patient just showed up as a blank slate, waiting for a diagnosis.
Just sitting on the exam table, totally open.
But today, our 2004 surgeon walks into exam room 3 and finds a patient who has already diagnosed themselves.
Oh, of course they have.
Yep. They have 3 browser tabs open on their phone. They've printed out their own MRI report from the patient portal.
And they probably Googled half the terms on it.
Exactly. And they already have a deeply entrenched opinion about a proprietary robotic surgical system they saw heavily marketed during a golf tournament over the weekend.
So the democratization of medical information, or I guess medical data, fundamentally changes the power dynamic in the room.
It flips it upside down. The surgeon is no longer the sole gatekeeper of information. They are suddenly thrust into this role of an editor or even a debater.
Right. And while they're having this intense debate with the patient, they look around for their scribe or maybe their resident to take notes, and the room is empty.
But it isn't actually empty.
No, because of ambient AI documentation.
Yes, the invisible scribe.
This was a massive curveball from the source text for me. There is an invisible algorithm quietly listening to the conversation, structuring the clinical note, and literally teeing up the billing codes.
And we really have to look at the mechanism of why that ambient AI is so disorienting for our time traveler.
I said spooky.
Well, yeah, but also because it's not just a fancy tape recorder, that AI is actively parsing the conversation to capture the specific complexities of the patient's condition.
Like what?
Like their comorbidities, their social determinants of health.
And why does the AI care about that?
Because in a value-based care environment, if that AI doesn't properly document that the patient has, say, poorly controlled diabetes and a heavy smoking history, the surgeon's risk-adjusted outcomes will look terrible if there's a complication.
Oh, wow. So if the patient gets an infection, the system needs to know it wasn't just a bad surgery, it was a high-risk patient.
Precisely. The AI is intimately tied to the surgeon's financial reimbursement and their legal profile.
It's basically acting as a real-time auditor in the room.
A very quiet auditor.
And the surveillance doesn't even stop when the patient leaves the clinic.
Not at all.
The source points out the post-operative ecosystem. The surgeon's practice is sending out automated text messages through these recovery apps the morning after surgery to track pain scores and range of motion.
Right. Compare that to 2004, where the patient just sort of disappeared until their 2-week follow-up.
You just hope they were doing okay.
Exactly.
Yeah.
Now, the data stream is continuous. It's unprompted. And most importantly, it demands oversight.
You can't just ignore the alerts.
No, legally and clinically, you have to respond to that data.
But wait, we haven't even talked about the biggest hurdle before the surgery even happens.
Like a site of care battle.
Yes. The
Yeah.
intense, exhausting negotiations about where to even do the operation.
Right.
A major case used to just default to the main hospital, right? You just book the OR.
That was the only option.
Now, our time-traveling surgeon has to justify to payers, to hospital administrators, and to the patient why a procedure should not happen in a lower-cost ambulatory surgery center.
The structural default has completely flipped.
So when you aggregate all these elements, the AI, the metrics, the informed patients, the automated recovery apps, the site of care battles, you really see the complete picture.
The source argues brilliantly here.
It does. It says for practitioners who define their identity solely by the 60 to 90 minutes the patient is asleep, all this surrounding noise feels like an aggressive distraction from their real job.
It feels like an attack.
Yeah. They feel like the floor is moving beneath them because they're standing on this incredibly narrow definition of their profession.
And that's a dangerous place to stand.
Well, it sounds to me like the hospital systems and the insurance companies have basically turned the surgeon into an unpaid risk manager.
Okay, tell me more about how you're reading that.
I mean, think about it. They want the surgeon to absorb the financial liability of a bad outcome. They want them to manage the supply chain. And they want them to act as a glorified data entry cloak for the AI. But they haven't given them the administrative power to actually fix the broken systems around them. Is that what we're looking at here? Just a massive offloading of corporate responsibility onto the individual clinician.
Well, that is a compelling, if slightly cynical interpretation.
I've been called cynical before.
But I think it misses the underlying mechanism of this shift.
How so?
It isn't necessarily a malicious corporate offloading. It is a fundamental redefinition of where value is actually created in healthcare.
Where value is created. Okay, break that down.
Let's look at the implicit job description from a surgeon's training 20 years ago. The mandate was very linear.
Right.
To be technically excellent, you evaluate patients in the clinic, you operate, you manage the immediate recovery in the hospital, and you repeat.
Right, exactly. Like a closed loop.
And that loop worked beautifully because there was a definitive, unmoving center of gravity, the operating room.
The OR was the sun, and everything else orbited around it.
Exactly. The entire hospital infrastructure, the staffing models, the capital expenditures, the scheduling, it all orbited the physical space where the surgeon performed their craft.
Right.
Now, the source explicitly clarifies that this center of gravity is not collapsing.
The OR is still important.
The OR remains the most consequential part of the day, but the center of gravity is shifting. And more importantly, the surface area of value creation has expanded exponentially.
The expanded surface area, the text hits this so hard.
It's a great visual.
It really is. Because you're right, the cut and the closure are still the peak moments of intervention. But the metrics by which a surgeon is judged have sprawled out in every possible direction.
They're everywhere now.
Let's look at the logistics of patient optimization, for example. The source mentions managing a patient's A1C levels, monitoring their BMI, enforcing smoking cessation before they're even allowed on the OR schedule.
It's aggressive prehab.
Yeah. And if a surgeon operates on a poorly optimized patient and they develop a surgical site infection, that doesn't just hurt the patient. It fundamentally damages the surgeon's institutional standing.
Because in the modern era, a technical success that results in a readmission is a systemic failure.
Wow.
Right. The expanded surface area dictates that the surgeon is now responsible for the entire episode of care.
From start to finish.
Exactly. How did the surgeon triage the patient? Did they steer them to the most cost-effective surgical setting? Did the recovery actually land safely because the patient engaged with their physical therapy protocols?
I have to challenge the fairness of this, though.
Go for it.
You take someone who spent 14 highly intense years learning the exact biophysics and kinematics of the human knee.
14 grueling years.
They are an elite specialized cracksman.
Yes.
And now the system is saying, hey, your technical skills are great, but we're actually going to grade you on your ability to ensure a 65-year-old man sticks to his pre-op diet and remembers to log into an app.
It sounds absurd when you say it like that.
It feels like we're diluting their expertise. We're basically asking an elite mechanic to also pave the roads and refine the gasoline.
I love that analogy. But the concept of fairness is a luxury the current healthcare economy simply does not afford.
Fair enough.
The uncomfortable truth that the source material forces us to confront is this: surgeons are being measured on this expanded surface area, regardless of whether they signed up for it, regardless of whether it feels fair, and regardless of whether it was in their medical school brochure.
Whether they signed up for it or not. That is a brutal reality check.
It is brutal if you resist it, but it is highly strategic if you recognize it.
Strategic how?
Recognizing this shift is the sole difference between navigating a career on purpose and feeling perpetually victimized by administrative creep.
Victimized. I see that a lot.
Right. If a surgeon insists their job is only what happens under the OR lights, they will constantly feel besieged by these new demands. They'll be miserable.
Yeah, they'll fight it every step of the way.
But if they accept the expanded surface area as the actual modern definition of the job, They can begin to build systems, they can leverage technology, and they can reclaim their agency.
Reclaim their agency. And speaking of that, the text dives into the most concrete way surgeons are actually attempting to take back control of this expanded surface area.
Yes, the big move.
It's a massive structural migration. We are talking about the explosion of the Ambulatory Surgery Center, the ASC,
It's everywhere now.
the sheer volume of procedures.
Yeah.
I mean, total joints, complex ACL reconstructions, massive rotator cuff repairs that have moved from the traditional inpatient hospital setting to the outpatient ASC is staggering.
It is arguably the most consequential structural shift in musculoskeletal care in our lifetimes.
Without a doubt.
But the geographic move, just changing buildings, is only half the story.
Right.
The source text focuses heavily on the operational detail that truly matters here, which is ownership.
Ownership.
Yes, surgeons are increasingly moving their cases to centers where they hold a financial equity stake.
Which completely rewrites the psychology of the job.
Absolutely does.
It's not just, oh, I'm driving to a smaller building with easier parking. It's, I personally own a piece of the building I am walking into.
If we look at the historical context, the physician in the traditional inpatient hospital was essentially a highly skilled guest worker.
Guest work.
Yes. They were a craftsman inside an institution earned and operated by someone else entirely.
Right.
The hospital absorbed all the risk. They managed all the friction. The hospital hired the nurses. They negotiated the supply contracts. They handled the sterile processing. And they dealt with the massive billing department.
So they were basically the talent on a massive cruise ship.
Exactly.
They show up, they perform their brilliant routine, and the ship handles the navigation, the plumbing, and the buffet.
That is a very helpful way to visualize it. But when that surgeon transitions to an ASC where they are a part owner, that guest worker identity just vanishes.
It evaporates.
They transform into a small business owner who just happens to possess a highly specialized craft.
And the mental load of a small business owner is a completely different beast.
It's exhausting.
You don't just worry about the anatomy of the shoulder anymore. You are agonizing over throughput.
Throughput is everything.
Let's look at what that actually means. Say it's a Tuesday morning. In the old hospital model, if a room turnover takes 45 minutes, the surgeon might get annoyed. Maybe they go grab a coffee in the lounge, but their paycheck doesn't change.
Right. It's the hospital's lost time.
But in the ASC model, that 45-minute turnover is actively burning their own capital.
They feel it in their wallet.
Yes. They are suddenly hyper-aware of the scrub tech's efficiency.
They are forced to optimize the case mix for financial viability, too.
Case mix.
Yeah, you cannot sustain an ASC by only performing complex, low-margin procedures that consume hours of OR time.
Ah.
The surgeon must strategically thread in shorter, higher-margin cases just to subsidize the facility's overhead. They are suddenly making clinical scheduling decisions based on macroeconomic realities.
And what about anesthesia? The source brings this up, and it's fascinating.
The huge point of stress.
Right, because in a hospital, anesthesia is just a given. You show up, someone puts the patient to sleep.
I don't even think about it.
But in an ASC, as the owner, you have to aggressively vet your anesthesia partners.
Yes.
You aren't just looking for clinical competence. You are relying on their specific ability to safely manage slightly sicker patients in an outpatient setting.
It's a delicate balance.
Because if your anesthesia group is too conservative and they cancel cases, your business loses money.
Right.
But if they're too aggressive and a patient crashes without an ICU down the hall, you face a catastrophic liability.
It requires a level of operational oversight that residency simply does not prepare you for at all.
Not even a little bit.
You're managing staffing shortages when the hospital down the street offers your lead nurse a massive signing bonus.
Oh, the poaching is real.
It is, and you are cultivating a reputation. Historically, the glowing letters on the side of the massive hospital building drove the patient volume.
The hospital was the brand.
The hospital was the brand. Now, as an independent ASC owner, your personal clinical brand, your center's efficiency, and your direct-to-consumer reputation are what keep the lights on.
The cognitive load is immense.
Immense.
And the text points out a really fascinating divide in how this is playing out on the ground. There is a massive generational split in how surgeons perceive this whole business craftsman hybrid model.
The psychology behind this split is absolutely critical to understand the current friction we see in medical groups.
Okay, lay it out for us.
Consider a surgeon who trained 30 years ago, during the peak of the inpatient hospital-centric era.
The golden age, as they call it.
Right. They mastered a system where they could focus with absolute purity on their clinical excellence. The system completely insulated them from the business mechanics.
They just operated.
For that generation, the transition to the ASC ownership model, the necessity of looking at profit and loss statements, dealing with supply chain hiccups, managing staff disputes, is experienced as a profound professional loss.
A loss? Yeah, they feel like it's a bait and switch.
Exactly.
They signed up to be healers, and the system basically forced them to become middle managers and accountants. They mourn the simplicity of just fixing bones.
Exactly, the sentiment. It feels like a dilution of their calling.
Yeah.
Now, contrast that with a surgeon who completed their fellowship in the last, say, 3 to 5 years.
The new guys.
They have no memory of the insulated inpatient era. For them, this hybrid business owner model is not a degradation of the profession. It is the default reality.
It's all they know.
Right. They expect to have equity. They expect to understand case costing. They view the business aspects not as an annoying distraction from the surgery, but as the fundamental framework that actually grants them the autonomy to perform the surgery on their own terms.
It's a completely different emotional relationship to the exact same job.
It really is.
But as complex as the structural side of the business has become, the source text pivots to something even more overwhelming.
Oh, here we go.
It's not just where they operate or how they fund the building. It's the actual cognitive process of deciding what to do in the first place.
The informational environment.
Yes. It has become a chaotic, high-stakes tidal wave.
We are transitioning from the logistics of care to the epistemology of care.
Epistemology, big word.
Well, it just means, how does a surgeon actually know the right thing to do anymore when the inputs competing for their attention have multiplied exponentially?
Let's rattle off the barrage of inputs the text lists, because honestly, it sounds exhausting just to read.
It's a lot.
First, you have imaging AI, and this isn't just software making an MRI clearer.
No, it's generative.
Right. This is AI actively reaching into the read, highlighting anomalies, and suggesting diagnoses that the surgeon now has to legally and clinically address, even if they completely disagree with the algorithm.
Which happens a lot.
Yeah.
And then you have the capital equipment demands.
Yeah.
The robotic surgical platform.
Oh, the robot.
These are multi-million-dollar investments by the hospital or the ASC. They are not merely tools. They are financial entities demanding a return on investment.
They need to be used to pay for themselves.
Exactly. This creates an institutional pressure on the surgeon to utilize the robot just to justify the purchase, adding a heavy economic variable to a strictly clinical decision.
And then the patients themselves become data generators.
The wearables.
Yes, the text highlights wearables. Patients are showing up to routine follow-up visits with Apple Watches, Aura Rings, Whoop straps.
It's constant tracking.
They're dumping these unprompted, continuous streams of biometric data, sleep architecture, heart rate variability, gait analysis, directly onto the surgeon's desk and asking, so what does this mean for my hip?
The source labels this brilliantly. Data nobody asked for.
Data nobody asked for.
It forces the surgeon to interpret consumer-grade metrics that completely lack established clinical validation pathways.
It's just noise.
It is. But among all this noise, the text singles out the specific, really insidious complexity of biologics.
Biologics. So we're talking PRP, stem cell injections, orthobiologics.
Wild West.
The promises are massive, and the source makes a very careful distinction here, which I appreciate. Some of these biologic treatments have very real, peer-reviewed merit.
Yes, they do.
But some of them are absolute, unadulterated marketing fiction.
And this is where the informational bottleneck occurs.
Right.
The mechanism of the problem is rooted in how patients actually consume medical science. A patient considering a stem cell injection for their knee is not logging into medical journals to parse double-blind, placebo-controlled, randomized trials.
Definitely not.
They are listening to a 3-hour podcast featuring a professional athlete who claims a specific injection cured their career-ending injury.
Or they're watching YouTube videos.
Exactly. They're reading highly optimized marketing copy from wellness clinics.
So the patient comes in completely sold on the hype. And the surgeon knows that the actual cellular reality of that stem cell injection might just be like a mild anti-inflammatory response. It's not the magical cartilage regeneration the podcast promised.
Precisely. Therefore, the surgeon is forced into the role of the ultimate filter. They cannot simply rely on their technical ability to inject the knee. They have to actively deprogram the patient's marketing-induced expectations.
Which takes so much time.
It takes forever. They have to explain the actual biological mechanism of action and justify the out-of-pocket cost versus the proven efficacy of conservative management.
Right.
They must parse the legitimate science from the aggressive marketing on behalf of a highly motivated, often financially vulnerable patient.
Which perfectly sets up the central dilemma of modern practice.
The menu problem.
The menu problem. I think this is the most vital concept in the entire deep dive. The source gives a very specific, highly illustrative clinical example, treating a meniscal tear in a 45-year-old recreational runner.
It is the perfect microcosm of the modern MSK landscape.
Let's look at the mechanics of this. 20 years ago, if that 45-year-old runner walked into the clinic, the menu is basically a Post-it note.
Very brief.
There were maybe 3 reasonable approaches. You could arthroscopically clean it out, you could try to repair it, or you could tell them to take some ibuprofen and rest.
That was it.
It was a small, curated dire menu. You have chicken, beef, or fish. The surgeon essentially acts as a waiter, taking the order and executing the meal.
The limited options provided an inherent clarity. The standard of care was very narrow.
But today,
Yeah.
the text points out that for that exact same patient, there are arguably 10 different defensible ways to approach the problem.
Let's examine the expansion of that menu because it's wild. Today, that patient could be offered a partial meniscectomy, a complex repair with biological augmentation, a specialized physical therapy protocol with blood flow restriction,
A PRP injection, a hyaluronic acid injection,
an unloaded brace, experimental peptide therapies, weight loss management.
and one of the most vital options the text includes, which takes immense clinical courage, by the way, is doing nothing thoughtfully. Active conservative management.
Yes.
The menu has gone from a Post-it note to one of those sprawling 20-page restaurant menus that have sushi, Italian, and breakfast all day.
Like a Cheesecake Factory menu.
Exactly. It is paralyzing for a patient. They don't need a waiter to just read them the list. They desperately need a culinary guide.
They need a sommelier.
Yes, they need a sommelier for your knee to tell them why the PRP pairs well with the PT, but why the surgery might actually be the wrong choice for their specific lifestyle.
And this transition from waiter to sommelier requires a completely new cognitive skill set.
It's totally different.
It is no longer sufficient to merely be technically capable of performing the 10 items on the menu. The new indispensable skill is what the source defines as editorial judgment.
Editorial judgment. Like the editor-in-chief of a magazine deciding what actually makes the front page, cutting out all the noise and presenting a coherent story.
That is the exact mechanism. Because every single one of those 10 options for the meniscus comes with a massive, dense evidence base.
Right.
Every option has its own evangelist standing on podiums at medical conferences, arguing it is the absolute future of medicine. Every option has its own multi-million-dollar direct-to-consumer marketing campaign.
So much noise.
The surgeon who cultivates this editorial judgment, who can synthesize the conflicting literature, filter out the industry bias, and present a clear, highly tailored recommendation to the patient, that surgeon successfully transitions from a mere technician to a trusted advisor.
But what happens when a surgeon doesn't develop that editorial judgment? Because the source outlines 2 very specific, very dark failure modes for practitioners who just get crushed by the menu problem.
Yeah, these are tough to see in practice. The first failure mode is a retreat into dogma.
Dogma.
Faced with an overwhelming amount of conflicting data and 10 different options, the surgeon mentally shuts down the menu. They just simply over-recommend their personal favorite procedure.
Oh.
Regardless of the nuance of new literature or the specific demands of the patient's lifestyle, they apply the exact same solution. They ignore the complexity of the landscape because engaging with it is just too cognitively demanding.
It's a defense mechanism.
Totally.
They convince themselves that my way works best in my hands, which conveniently ignores the fact that 5 better, less invasive options might have been invented in the last decade.
Exactly.
But the other failure mode is almost worse because it looks like good medicine on the surface.
Right. The second failure mode is paralysis through abdication.
Abdication, giving up.
Yes. The surgeon is so overwhelmed by the 10 options and so terrified of making the wrong choice or maybe contradicting a patient's internet research that they completely abandon their medical authority.
Yeah, how does that look in the room?
They walk into the room, present the patient with a bewildering array of pros, cons, and statistical probabilities for all 10 options, and then step back and recommend absolutely nothing.
Well, Bob, We could do the surgery, but there are risks. We could do the injection, but it might not work. We could do PT, but it takes time. What do you want to do?
Exactly.
That is a terrifying position to put a patient in.
It is the illusion of informed consent, masquerading as clinical guidance.
Man, that's well said.
The patient doesn't have the 14 years of biomechanical training to weigh those variables. They want the guide. Forcing the patient to make the ultimate clinical decision out of a menu of 10 complex options is a failure of the physician's core duty.
And to be that trusted guide, to effectively communicate that editorial judgment so the patient actually believes you. That brings us to what the source calls the least discussed, but arguably the most critical shift in the entire profession.
But a relational layer.
It's the relational layer of the job.
The text makes a very bold claim here. It says soft skills are no longer a luxury. They are a hard clinical strategy.
To understand why, we really have to look at the modern patient profile the text describes.
They've changed.
They have. We are no longer dealing with the deferential, quiet patients of the 1980s who just nodded and took their medicine.
Those days are gone.
The modern patient comes in highly informed. Sometimes they are genuinely well-informed because they've read legitimate literature.
Sure.
Often they are half-informed. And occasionally, as the author brilliantly phrases it, they are aggressively wrong.
Aggressively wrong. It is a very humorous phrase, but it captures a profound clinical friction.
It really does.
The internet provides patients with unlimited access to medical data, but it provides zero framework for contextualizing that data.
Right.
They arrive in the clinic armed with conviction, but severely lacking comprehension.
But let me push back hard on this.
Please do.
Let's say I'm running a busy ASC clinic. I have 30 patients to see today.
A packed schedule.
A patient comes in, aggressively wrong, clutching a stack of printouts from some fringe TikTok influencer claiming that a crushed pineapple poultice and alkaline water will magically cure their bone-on-bone osteoarthritis.
I've seen it happen.
If I spend 15 minutes carefully validating their feelings about pineapple juice, I am backing up the entire waiting room.
Sure.
I'm making other patients angry. I'm losing money. How is it a clinical strategy to indulge that? Isn't my job to just lay down the biological facts, debunk the nonsense quickly, and move to the next room? I mean, time is literally money.
Your pushback represents the exact mindset that the source material is trying to dismantle.
Oh, really?
Yes. Simply laying down the facts and moving on fundamentally misinterprets the mechanism of modern patient psychology.
Oh, so?
If you dismiss that patient's printout in the first 30 seconds, you might save 10 minutes in the clinic that day. But you will pay a massive compliance tax for the next 6 months.
A compliance tax? What does that actually look like?
The text points out that modern patients desire partnership. When they bring in those absurd printouts, they're not actually asking for a debate on cellular biology.
They're not.
No. They're expressing a desperate desire for agency. They want to know that their fear, their research, and their voice are taken seriously. If you alienate them by immediately asserting your intellectual dominance, the partnership shatters.
You lose them.
Completely. They will not adhere to your physical therapy protocols. They will call your on-call nurse every single night with minor anxiety-driven complaints because they do not trust the primary plan.
Right.
They might even show up at the emergency room for normal post-operative swelling simply because they feel disconnected from you.
So the 15 minutes I spend validating them up front actively prevents 5 hours of uncompensated, chaotic downstream work.
Precisely. And this introduces a profound paradigm shift that we really must underline here. Patient experience is no longer a service variable. It has evolved into a clinical variable.
Let's clarify those terms for the listener. What is the functional difference between a service variable and a clinical variable?
Historically, bedside manner was viewed strictly as a service variable. It was akin to a hotel's star rating.
Like, did they leave a mint on the pillow?
Exactly. Was the receptionist polite? Were the magazines in the waiting room from this decade? Was the doctor pleasant? These things are nice to have, and they might improve your Yelp reviews, but they do not alter the biomechanical success of a ligament repair.
But the source is arguing that the relationship itself actually alters the medical outcome.
It absolutely does, through direct physiological and behavioral mechanisms.
Well, physiology.
Yes. If a patient fundamentally trusts their surgeon because they felt heard, because their questions were addressed without condescension, because a genuine human connection was established, their anxiety levels decrease.
And lower anxiety means better healing.
Exactly. Lower systemic anxiety improves physiological healing. Furthermore, A trusting patient is far more likely to communicate early signs of a complication, such as a superficial infection, rather than ignoring it because they felt too intimidated to call the clinic.
That makes total sense.
Therefore, the trust built in the exam room directly influences the biological success of the intervention. Soft skills dictate hard outcomes.
That reframes everything. Bedside manner isn't just about being a nice person, it's literally a tool in the surgical tray.
A critical tool.
And the text provides an incredible, highly tactical piece of advice for deploying that tool. It focuses on the first 60 seconds.
This part is so practical.
The author argues that surgeons must treat the first 60 seconds of a routine clinic visit with the exact same reverence, intense focus, and preparation as the first 60 seconds of a complex surgical operation.
Consider the choreography of the operating room. When a surgeon makes the first incision, they are not distracted.
No way.
They have completed the surgical timeout, they have reviewed the imaging, they are mentally locked into the anatomy.
But in the clinic, the default behavior is completely different.
It's often chaos.
The surgeon often stumbles into the room, staring down at a laptop screen, apologizing for running 20 minutes late, fumbling to pull up the right chart, and asking a question the patient literally just answered on the intake form.
Which destroys trust instantly.
Right. The source is demanding a hard stop. It says, pause before you touch the doorknob, take a breath, look at the chart, identify one personal detail.
Yep.
The moment you cross the threshold into that exam room, those first 60 seconds are the most critical, high-leverage moments of the entire encounter.
Because that first minute sets the irreversible tone.
Irreversible.
It establishes your authority without projecting arrogance. It signals to the patient that they are the absolute center of your attention, which immediately de-escalates that aggressively wrong patient we talked about.
It disarms them.
And it opens the door for the collaborative partnership required for healing.
If we follow this logic to its conclusion, it leads to a reality that might terrify some of the older guard.
Oh, it does?
Because this isn't about being universally agreeable or having a naturally bubbly personality. It is pure, calculated clinical strategy.
Exactly.
The surgeons who are dominating their markets right now, the ones with completely full ASC schedules and stellar outcome metrics, are not necessarily the absolute best technical operators in their zip code.
That is the ultimate realization.
It's mind-blowing.
The technical floor in modern orthopedics is exceptionally high. Thanks to advanced fellowships, robotics, and highly standardized implants, most surgeons can technically execute a highly competent procedure.
The baseline is great.
Right. The technical skill is no longer the primary differentiator. The true differentiators, the surgeons who build massive, sustainable practices, are the ones who have mastered this relational layer.
The ones with the soft skills.
They possess the editorial judgment to navigate the menu problem, the patience to de-escalate misinformation, and the strategic discipline to win the patient's trust in the first 60 seconds.
Okay, we have dissected the shifting center of gravity, the structural migration to ASCs, the overwhelming noise of the menu problem, and the strategic necessity of the relational layer.
We've covered a lot.
But I want to make sure we don't just leave our listener with a philosophical headache.
Always need action steps.
Right. The source material intentionally concludes with a playbook. It offers concrete, actionable takeaways for the individual practitioner, the residency director, or the clinic manager to navigate this identity shift on purpose rather than just surviving it.
Let's get into them.
Let's explore these 4 tactical moves. The first directive from the author: write the real job description.
This sounds simple, but it is an incredibly powerful cognitive exercise.
How so?
The text advises the reader to literally throw away the official human resources file. Ignore the hospital's generic documentation of what a surgeon supposedly does.
Just ditch it.
Sit down with a blank piece of paper and ruthlessly document what actually consumes your cognitive energy this year, as compared to 5 years ago.
It's about making the invisible labor visible.
Yes.
You write down, I spend 4 hours a week aggressively managing my ASC's staffing shortages. I spend 2 hours a week deciphering AI-generated imaging reports. I spend 3 hours a week talking anxious patients out of useless, heavily marketed biologic therapies they saw on Instagram.
The psychological relief of formally naming these creeping responsibilities is immense.
Because it's finally on paper.
Right. The mechanism here is psychological framing. When these tasks are unnamed, they feel like illegitimate interruptions to your real work of operating.
They just feel like annoyances.
And they generate chronic resentment. But the moment you write them down as part of your actual modern job description, They transform. They go from being an annoyance to being a defined professional responsibility.
Once it's on paper, you can manage it, you can allocate dedicated time for it, you can hire support staff to delegate it, or you can build a system around it.
Exactly.
You reclaim your agency by defining the actual boundaries of your reality rather than the reality you wish still existed.
Beautifully said.
Yeah.
And this leads directly to the second tactical move, which addresses the overwhelm of the informational environment.
Okay, what is it?
The directive is, stake your claim on the menu.
Stake your claim. This is the antidote to the menu problem we discussed.
Yeah.
The advice is remarkably liberating. You do not have an obligation to offer every single option in the musculoskeletal universe. You don't have to be an expert in 20 different proprietary robotic knee systems and 5 variations of stem cell injections.
But the text includes a crucial caveat to this freedom.
What's the catch?
The author writes, vagueness is where trust quietly leaks out.
Oh, wow.
You cannot simply ignore the options you don't use. You must be explicitly clear, first with your own clinical philosophy, and then with your patients, about what you offer, what you don't offer, and fundamentally, why.
I cannot get over that quote. Vagueness is where trust quietly leaks out. Think about how that plays out in the clinic.
It happens every day.
If a patient asks a surgeon about a brand new robotic procedure they read about online, and the surgeon just shrugs and mumbles, I don't really do that, let's just stick to the traditional way, it works fine for me, the surgeon instantly sounds defensive, outdated, and threatened.
They appear to be retreating into the dogma failure mode we identified earlier.
Right. But if that same surgeon uses their editorial judgment and says, I am very familiar with that new robotic platform, I review the literature on it quarterly. However, based on the current peer-reviewed data regarding long-term survivorship and my own internal outcome metrics, I have intentionally chosen not to utilize it. I believe the traditional approach I use offers equal precision for your specific anatomy without the added risk of increased operative time. Boom.
The difference in patient perception is night and day.
It's massive.
You are not just blindly declining a menu item, you are transparently explaining the rationale behind your curation. You are demonstrating that you are fully engaged with the modern landscape, but highly disciplined in your application of it.
That level of explicit clarity is the absolute bedrock of the trusted advisor role.
It proves you are the executive chef writing the menu, not just a line cook intimidated by new ingredients.
Great tie back to the chef analogy. All right, the third tactical move in the playbook. Train the relational skill.
We must emphasize a vital distinction the text makes regarding this point. The relational layer, the ability to connect, de-escalate, and build trust, is a skill, not a personality trait.
This is a massive paradigm shift for medical training.
Huge.
Because the standard defense mechanism for so many doctors and really highly technical professionals in any industry is to claim biological destiny.
Oh, the I'm just an introvert excuse.
Yes. They say, look, I'm just an introvert. I'm highly analytical. I'm not a warm and fuzzy people person. I can't do the bedside manner stuff.
That excuse relies on a fundamental misunderstanding of the task. Personalities are largely static. They're the innate temperaments we possess.
Right.
Skills, however, are dynamic. They can be learned, practiced, analyzed, and refined through repetition. You do not need to possess an extroverted, naturally charismatic personality to master the first 60 seconds of a clinic visit.
You just need a clinical protocol for communication.
Precisely. You learn the tactical skill of asking an open-ended question and then actively listening without interrupting for at least 15 seconds. Which, by the way, studies show is incredibly difficult for most physicians.
15 seconds of silence feels like an hour.
It does. You learn how to sit down rather than standing over the patient, altering the physical power dynamic in the room. You learn to read the micro expressions of a patient who is hesitant to disagree with your surgical recommendation.
These are mechanical things.
These are tactical mechanical skills, no different than learning a specific suturing technique for a meniscus repair. They require deliberate practice, perhaps reviewing recordings of your own patient interactions, and a professional willingness to improve.
It's about taking the ego out of communication and recognizing it as just another vital instrument in your surgical tray that needs to be constantly sharpened.
Exactly.
And that brings us to the fourth and final takeaway from the source. Find honest peers.
The author points out that navigating an identity shift of this magnitude simply cannot be done in a vacuum.
It's too much.
The final tip is to locate 1 or 2 peers for radically honest conversation. But the source includes a highly specific parameter for this.
Yes, the text is adamant. This communication must happen entirely in private.
Absolutely private.
It cannot happen at regional conferences. It cannot happen on professional social media platforms. It cannot happen during grand rounds.
We have to analyze why the public sphere is explicitly excluded.
Why is that?
The public spaces of medicine, the podium presentations at national conferences, the heavily curated LinkedIn posts, the published case studies are inherently performative environments.
Oh, for sure. It's all about looking good.
They are spaces designed for broadcasting success, highlighting unblemished surgical technique, and projecting an aura of unshakable clinical confidence.
Nobody stands up at the microphone at the massive National Orthopedics Conference and says, "Hey, everyone, I just want to admit that I am completely overwhelmed by my ASC's supply chain issues. I don't truly understand the mechanism of half the biologics my patients are demanding, and I feel like I'm losing my identity as a surgeon."
It would be professional suicide in that environment.
Oh,
But the reality is, the pace of change is simply too aggressive, and the expanded cognitive load is too heavy to process in isolation. A practitioner needs a private sanctuary.
a safe space.
They need a trusted colleague, or perhaps a mentor or a partner in a different market, where they can admit confusion, express vulnerability, and honestly dissect the creeping changes in their job description without any fear of institutional or professional judgment.
It's the difference between trying to read a map by yourself while standing in a hurricane versus pulling the car over into a quiet garage with a friend and saying, "Are you seeing this too?" Because I think the roads have completely changed.
That is exactly it.
It is essential for long-term career sustainability and mental health.
Without a doubt.
Well, we have covered a tremendous amount of ground today, pulling apart the hidden mechanisms driving profession's evolution.
It's been a deep one.
Let's pull the lens back and summarize the overarching theme. The role of the orthopedic surgeon, and really this applies to almost any highly specialized medical field right now, is not shrinking.
The sky is not falling.
The sky is not falling. But the role is expanding in complex administrative and relational directions that simply do not show up on a traditional surgical case log. The practitioners who explicitly name the change, who accept the shifting center of gravity, who embrace the business realities of the ASC, and who intentionally invest their energy in honing their editorial judgment and relational skills. Those are the ones who will thrive.
And the ones who refuse.
The ones who refuse, the ones who insist the job is only what happens under the OR lights. As the text grimly warns, they will continue doing excellent surgery in a system that quietly stops rewarding them for it.
That is a stark warning.
To you, our listener, I want to issue a direct challenge based on today's deep dive. Take 5 minutes before your next case or your next clinic block and reflect on your own specific reality. What wasn't on your job description when you started training, but completely dominates your daily cognitive bandwidth now?
Write it down.
What is your version of the invisible scribe? Name it. Claim it as part of your actual job. And decide, right now, how you are going to manage it on purpose.
And as we close this analysis, I want to leave you with a final lingering thought that extends beyond the immediate text.
Give it to us.
We've spent this entire deep dive exploring how the modern surgeon must transition from a hospital-based craftsman into an hospital-based craftsman into an autonomous, business-owning, trusted medical editor in the ambulatory setting.
Right.
But if this structural and philosophical migration is truly successful, if the best surgeons master this new identity, and the true center of clinical gravity physically walks out the hospital doors and into the surgeon-owned ASC down the street, what happens to the traditional hospital system?
Oh, wow.
Will the massive inpatient institutions of the past, with their massive overhead and legacy infrastructure built entirely around that old centralized model of care, be able to survive when their primary engines of value creation have evolved past them?
That is a massive existential question for the entire healthcare economy, and definitely a topic for a future dope dive.
Absolutely.
Thank you for joining us on this exploration. If these insights resonated with your experience or challenged your assumptions, share this deep dive with a peer you respect. Maybe that one honest peer you can dissect these changes with in private. Until next time, keep looking past the procedure and focus on the job.